At OnlineMedEd, we walk you through every topic in detail, so you're ready for the boards and the wards. This segment of Psych Pharm dedicated to anxiety is going to be pretty fast. So I want you to see the spectrum of anxiety, from a really chronic anxiety, that's this smoldering level of worry. It impairs function because it's always there, but it has very few somatic symptoms and it's not very disruptive if you don't pay attention to it. This is effectively generalized anxiety disorder. And in the chronic anxiety state, you want to have a chronic treatment. In the chronic treatment of anxiety, psychotherapy without medications is the furthest to the left. But as we'll see, most of these disorders are going to respond to some level of medication. On that spectrum, you take it out to acute anxiety, which is sudden in onset, catastrophic and disruptive. It's like they're dying. This is panic disorder. And because you have acute anxiety, you're going to need an acute treatment. Acute treatment is an anxiolytic like benzodiazepines. On the chronic side, the answer is almost always going to be SSRI and SNRI. Either one, won't have to choose between them. This treats a chronic anxiety. But even if you don't have generalized anxiety disorder, those disorders which have an anxiety component that are there for a long time, things like obsessive compulsive disorder, post-traumatic stress, and yes, generalized anxiety disorder, can all benefit from the use of SSRIs, even though they're not necessarily specifically anxiety disorder. And if you'll recall from impulsive disorders, these do not respond to SSRIs. Technically, if you have someone on an SS or SNRI, there's the risk of serotonin syndrome. We talk more about serotonin syndrome in the catatonia lesson. On the opposite side of the spectrum are going to be the anxiolytics. These are the benzos. The benzodiazepines are used in panic disorder and are used to abort attacks only. You abort attacks only because chronic use of benzodiazepine creates a dependence. And a withdrawal of chronic benzodiazepine leads to the same syndrome as alcohol withdrawal, because both alcohol and benzos bind to GABA. So you can use benzodiazepines to treat alcohol withdrawal, long-acting benzos on a taper with rapid-acting benzos on top, or you can use rapid-acting benzos to abort acute panic attack. They should not be used to treat chronic anxiety because you'll end up with dependence. Rapid-acting benzos are going to be things like lorazepam, IV, and alprazolam, PO. Benzo withdrawal can be treated with longer-acting medications such as diazepam or chlordiazepoxide. And also don't forget about the specific phobia. The one that the boards love to test is going to be that of public speaking. You treat public speaking with a non-selective beta blocker, propranolol, nadolol, or atenolol. Theoretically, you have the risk of a decreased heart rate causing bradycardia, and long-term use may decrease mood. But since they're only using them as needed for public speaking, where their heart rate's probably going to be elevated anyway because they're anxious, you won't have any problems using beta blockers in those settings. That is Psych Pharm anxiety. In this lesson in the Psych Pharm series, we want to touch on antipsychotics. We're going to be paying most attention to the treatment of psychotic disorders, even though we know that antipsychotics can be used to treat other things. Let's start off with a little bit of pathology about antipsychotics. If you recall from our psychosis lectures, there are both positive symptoms, delusions, hallucinations, disorganized thoughts, and negative symptoms. Negative symptoms are going to be the anhedonia, the cognitive deficits, the lack of speech. Positive symptoms are things that are there that should not be. Negative symptoms are the things that aren't there but should be. Positive symptoms are driven by mesolimbic, and you'll see why this is important to know the location, mesolimbic D2C receptors, driven by dopamine. So that if you give stimulation to these receptors, they will produce positive symptoms, and therefore antagonizing those receptors will prevent the positive symptoms. The negative symptoms, doesn't really matter where they are the 5-HT1s, driven by serotonin. If you stimulate these receptors with serotonin, you will get negative symptoms. If you block serotonin, you will prevent these symptoms. Now, of course, it's not actually one-to-one, but what I want you to do through this entire lesson is learn a one-to-one association of pathology and also a one-to-one of side effect drug to the thing it's most known for. In history, what we made first were drugs that went after the positive symptoms. These are referred to as the typical antipsychotics, also called first-generation antipsychotics. And since they went after positive symptoms, not surprisingly, what they tried to do was antagonize mesolimbic D2C receptors. And by reducing the activity of dopamine there, the goal was to decrease the positive symptoms. The problem is that when we were early making drugs, that we didn't really understand these subtypes. So what we made were medications that blocked dopamine. And in general, what you're going to see for the typicals, as you increase potency, you are generally going to increase the extrapyramidal side effects. We'll talk about those at the end of the lesson. And it makes sense. If you got a dirty drug that blocks dopamine, it's going to work really well where you want it to. But it's also going to block dopamine really well where you don't. For example, in the nigrostriatal tract, blocking dopamine leads to the extrapyramidal side effects. In the tubuloinfundibular tract, blocking dopamine is going to lead to gynecomastia. It's a problem for men, and galactorrhea and amenorrhea in women. Take it for granted, as we'll discuss it more in endocrine and OBGYN, if you block dopamine, you disinhibit prolactin. Excess prolactin leads to gynecomastia, galactorrhea, and amenorrhea. And all these medications are going to have acetylcholine side effects, such as dry mouth and urinary retention. For the typicals, you should associate more potent, more effective, with more side effects. And I'm going to list these in descending order of potency, and therefore decreasing order of side effects. At the top is haloperidol. And surprisingly, this is what you're going to see used in the acute setting and in the hospital. It works really well in the acute setting to subdue somebody. But you're not going to see someone on haloperidol orally long-term because of the extrapyramidal side effects. Next up is fluphenazine. And I want you to remember haloperidol and fluphenazine as the potent typical antipsychotics. For the non-potent, I want you to learn thoradazine and chlorpromazine. Haloperidol, fluphenazine, potent, thoradazine, and chlorpromazine are going to be weaker but have less side effects. Throughout the course of history, when we realized, hey, there's more to it than this, just this dopamine receptor, we started making drugs that could target both positive and negative symptoms and were more selective for the ones we wanted. We made clozapine. I'm going to say that to the end. It's the best antipsychotic we've got. It's also the most dangerous, so it's used as last resort. Every atypical antipsychotic that's come after has tried to duplicate clozapine without the side effect profile. So the atypicals, also called second-generation antipsychotics, go after both positive symptoms in the way of D2C receptor antagonism as well as the negative symptoms by attacking the serotonin receptors. And because we've been more specific to D2C, rather than just saying block dopamine, we've had a decrease in the overall incidence of extrapyramidal symptoms. Now, these are listed in no particular order. We don't have a potency gradation like we do for typicals. The ones I want you to commit to memory are quetiapine, olanzapine, and risperidone. I'm going to put a dashed line here as I did for the typicals, not because this is potent, unpotent, but because above the line are the ones you're going to be seeing most often as primary therapy. Some of the other ones, aripiprazole and ziprasidone, you'll see less often, so these are the ones that are probably going to come up on the test. Here, what I want you to do is memorize the most likely side effect profile. Quetiapine causes the side effect of somnolence. And so, since it makes people sleepy, it can be used to treat insomnia. We also saw that it can be used as an antipsychotic mood stabilizer being used to treat bipolar or mania. So if you have a person who has mania and psychotic features, you want to use quetiapine. If you have someone with insomnia and psychotic features, you want to use quetiapine. Associate olanzapine with metabolic syndrome, weight gain, and diabetes. Risperidone has the highest incidence of extrapyramidal symptoms, and there's not really anything I want you to learn about aripiprazole or ziprasidone. But also realize that all of these have problems with QTC prolongation and acetylcholine side effects. If you're going to put someone on one of these medications, they need a 12-lead EKG before and after to ensure the QTC is not prolonging. The best medication at treating the symptoms we have is clozapine, in a class of its own. It is the best drug we've got. It is also the last resort. That is because it kills people. It causes agranulocytosis. You need to have failed at least 2 antipsychotics, not worked on maximum doses, and then get on a list with CBCs weekly, then monthly for a long time until you can get off this, change it to something else. Clozapine is the best we've got, but it's the last resort because the side effect of agranulocytosis, the incidence is high enough where the number needed to harm is low enough for us to essentially take it off the market, except in the worst cases, the most refractory. So you must be asking, well, that's great. How do I now choose the medication, right? Which drug do I use in which cases? So making the right choice when you choose the drug. What I want you to see is that it comes down to formulation. You're going to have a normal patient who's going to be compliant, who wants to take their meds. Then you're going to have the person who is non-compliant. But this is further broken down into the person who's in the agitated in the ER and needs to be subdued, someone who can't swallow pills or doesn't want to, but you don't have access to a syringe, and those people who are chronically non-compliant that need some form of preparation that stays in them longer. The thing is, when you start antipsychotics, you just start at a low dose. And because the dosing is daily or twice a day, you can end up figuring out if this dose is going to work in 24 hours. So you just simply increase the dose every day until the symptoms are controlled. You reach a max dose and it's not working, you try something else. If you have side effects, you either decrease the dose or remove it and try something else. The problem is, though, that if you just miss a dose or 2, the effect wears off, the psychosis comes back. So someone who's going to take their medications, you want a clean side effect profile. You want something that's going to be easy to take and not cause a lot of side effects because they are trying to control their symptoms. This, in a normal, compliant patient, you want to use the atypicals. You use one of them, you use them orally. The non-compliant patient, though, and depending on the situation, is going to use different formulations. If they're agitated in the ER, you might need to use an IM preparation with rapid-acting medication. Here you're going to use olanzapine and haloperidol. Haloperidol is atypical, and olanzapine is atypical. But haloperidol and olanzapine are often used intramuscularly. We saw this also as the B52 shot in trying to subdue someone who's agitated and anxiety. Dysphagia means they can't swallow pills, or they won't. You don't necessarily want to stick somebody with a needle every day, so what you can do instead is use the oral dissolving tablets. As long as they close their mouth, it will be absorbed even if they don't swallow. Again, we see olanzapine and risperidone. And lastly, a person who's chronically noncompliant, who just doesn't want to take their medications, needs a formulation that lasts longer. This is going to be the depot form. Again, we see olanzapine and risperidone. Olanzapine and risperidone are useful and atypicals for a non-compliant patient. Haloperidol is very potent and it can be used to subdue somebody. And lastly, when the patient has failed everything else, that is when we use clozapine. I want to close out this lesson discussing and differentiating the extrapyramidal symptoms. There are 4. Akathisia, acute dystonia, dyskinesia, and this is frustrating because they share the same word in their name, tardive dyskinesia. Now I'm going to put a dashed line between tardive dyskinesia and dyskinesia. That is because tardive dyskinesia is irreversible and, unlike the others, has no treatment. Akathisia is the feeling of restlessness, the urge to move. This can be a real problem. If you have an agitated patient, you give them an atypical antipsychotic, and all of a sudden they start getting squirmy. They're supposed to be sitting still in an interview, but they're starting to move a lot. It looks like they're getting more agitated, so you might be tempted to give them another dose. You do that, you make the symptoms worse. It's the intact reasoning, logical thought, not psychosis, and the urge to move, that's akathisia. And the way you treat this is by decreasing the dose. Alternatively, you can use beta blockers or anti-acetylcholine medications, which you're going to see used first line as benztropine, diphenhydramine can also be used. Acute dystonia is going to be any contraction of a major muscle group, hand wringing, arm contraction. What you're going to see on the test are 2 particular features: oculogyric crisis and torticollis. Torticollis is going to be contraction of sternocleidomastoids. Their head is twisted away from them. And oculogyric crisis is their eyes get locked in one position. The classic presentation for this is someone who's looking up, trying to go downstairs. They actually can't look down, so in order to look down, they have to bend over at the waist to see where they're going, and they tend to fall. Oculogyric crisis, torticollis, hand wringing, all examples of acute dystonia. Use anticholinergic medications such as benztropine and diphenhydramine. Dyskinesia is the same thing as bradykinesia, and this is Parkinsonism, which makes sense. You inhibit dopamine receptors in the wrong place. You kill the go signal. In Parkinson's, they lose the neurons that make dopamine. In side effects, you block the receptors of that dopamine. Mask-like expression, shuffling gait, cogwheel rigidity, bradykinesia, dyskinesia mean the same thing. Treat it with anticholinergics. Benztropine, diphenhydramine. We used to use amantadine to treat Parkinson's, and still on the list for treatment of the EPS symptoms, but since we don't use amantadine anymore to treat Parkinson's, likely it's going to be the wrong answer to choose for EPS. Tardive dyskinesia is chronic and lifelong, and it is of the face. What you'll see is grimacing, sticking out of the tongue, moving the bottom of the jaw. And once you have it, there's nothing to do for it. But you usually must be on a medication for greater than 6 months. And once you get it, the duration is forever. If you keep treating, they will get worse. So what you need to do instead is screen people who are on medications and stop the medication if they develop tardive dyskinesia symptoms. Usually every 6 months you screen them. So this is a long one. There's a lot up on the board, so it seems overwhelming. Let's go through it real quick. Positive symptoms, mesolimbic D2C. Negative symptoms, serotonin. The typicals block the positive symptoms, D2C. Because they are dirty drugs, they have increased risk of extrapyramidal side effects. Haloperidol is strongest. The atypicals got cleaner, they got more focused. They treat both the positive symptoms and the negative symptoms. Quetiapine treats insomnia and bipolar. Olanzapine causes weight gain and diabetes. Risperidone has the highest risk of EPS. All of them have risk of QTC prolongation and acetylcholine side effects. Clozapine, best we've got, last to use because it causes agranulocytosis. You pick the drug based on the patient. The formulation that is oral, daily, or twice a day is used for the compliant patient. For the non-compliant patient who needs to be subdued, intramuscular injections. For the person who can't swallow or won't swallow, oral dissolving tablets. Patients who are chronically non-compliant get a depot. And separate akathisia, which is restlessness, from acute dystonic reaction, which is oculogyric crisis or toticollis, dyskinesia, which is Parkinsonism, all of which are treated with anticholinergic medications like benztropine. And don't miss tardive dyskinesia, which you should screen for and stop the offending agent should it develop. That is Pharm Anti-Psychotics.